Aibovan and a very good evening to all our viewers here on TV1. I'm Dr. Dilshan Fernando. When you really analyze that greeting, Aibovan, we're basically wishing another person a long and healthy life. And we as doctors, that is what we strive to achieve in our patients, to get them a long and healthy life. And in doing so, we have noticed that most of our patients don't have the basic understanding of what their diseases are about. And keeping that as our objective, we bring to you a brand new program right here on TV1, where we discuss common medical diseases that you, our viewers, face on a day-to-day basis, and we try to break them down into small, digestible particles so that you have a better understanding of what they are about, what treatment modalities are available for you, and what you can do to prevent them. And as our first topic of discussion, I thought of talking about the biggest challenge that global healthcare has had to face for the past century, and that is none other than the pandemic of COVID-19. Since its beginning in November 2019, we have faced what one might call a roller coaster ride, where we faced certain humps and bumps. But there was a light emerging at the end of the tunnel with the emergence of the vaccines. However, in the current context, our viewers might have certain confusions regarding the new trends of COVID-19. So, in our effort to untangle those confusions, we are in conversation with Professor Suranjith Senavirathne this evening. He is a consultant in clinical immunology and allergy at the Royal Free Hospital and University College in London, and he is joining us via Zoom this evening. A very good evening to you, Professor, and thank you very much for joining us this evening on Healthline.
Good evening, Dishant. Thank you very much for inviting me.
To start off, sir, now since the beginning of COVID-19, we have seen many variants of concern. First of all, for the benefit of our viewers, please explain to us, why do viruses have such a huge potential to mutate, and also comparing COVID-19 to the other viruses, is there a higher potential in this virus as opposed to the others?
Yes, so good question. So now, if we go back to baseline and find out what do these organisms do, bacteria, DNA viruses, RNA viruses, that is based on the genetic code that is found in the virus, they want to spread from person to person and to survive long term. Now, when it comes to the viruses, they multiply more rapidly, and while they are multiplying, they could have changes in their genetic code. The DNA viruses and the RNA viruses both multiply, and those changes can be significant. That is, it can cause effects in the clinical picture, or else it can really make them less dangerous. So you find that certain viruses like the flu virus, the influenza virus, change very, very frequently, or HIV changes frequently. And that is one reason why it was difficult to get a vaccine for HIV so far. There are several other reasons, but one other reason, the flu virus changes, and that is why we had to give a booster dose every year, taking into consideration the changes that occur. So when it comes to the SARS-CoV-2 virus that causes COVID-19, again, there are changes, and we have close to about 5,000 changes that have occurred since the virus came into sort of knowledge in the world. And some of those changes, what we call the variants, are variants of concern or variants of interest, and we'll talk about that later. So viruses multiply, or what we call replicate, and during that process of replication, you find, or multiplication, you find small changes, mutations, and that leads to variants.
Yes, and moving on, sir, since the Spanish flu in 1918, there has not been a pandemic for the past 100 years. What makes COVID-19 so transmissible, so virulent, that it has gone to the magnitude as we see in today's context? What makes it so transmissible?
Yes, Dilshan, if you look at the Spanish flu, it was a respiratory infection. So when it comes to the respiratory infections and the other SARS-CoV-1, etc., all those were respiratory infections. So the chance of it being transmissible is higher, especially in certain countries. You have the seasons where people are indoors, and then you have the transmission can be very much high. And you saw the number of cases increase in certain regions of the world during the the colder months. And what happens with the SARS-CoV-2 virus is the one that causes COVID. It uses its spike protein, the protein on its surface, to bind very well to a receptor called an ACE receptor. So spike protein, ACE receptor, which most people would have heard by now. And the ACE receptor is found on many cells, on the respiratory system, the gastrointestinal cells, the heart, the liver, the kidney, etc. But since the respiratory system, the upper airways are exposed to the environment, you find that if the virus enters the person at a sufficiently high titer or level, you find that it binds to the receptor, it enters the cell, multiplies, spreads from one cell to another, and then spreads from person to person and causes disease during that process. So a lot of the pandemics, we had other pandemics too, but a lot of the pandemics could be traced to respiratory because the chance of it being transmissible is so great, and a pandemic means it is spread across the globe, and that's how they classify a pandemic. So that is to be taken into consideration.
Now, talking about transmissibility, the Lancet, which is a globally acclaimed medical journal, recently carried an article which claims that the COVID-19 virus is now airborne. What sort of implication does it have on the transmissibility of the virus, and what sort of precautions, extra precautions I should say, should we take to protect ourselves from this now?
Very, very good and topical question, Dilshan, especially with the news about what the Americans have been saying over the last 2 days, the CDC and Dr. Fauci, with regards to wearing masks. So in March 2020, you found that the WHO said it was not airborne. But then after that, they have rolled back from that position. And now we know that there have been several reports in the sort of big journals, which are pointing to the possibility of airborne transmission being part of the transmission process. So you have two ways that a organism can be transmitted. One is droplet. Now the droplet is a bigger, it's the liquid with the virus, and it tends to fall close to where the person is. When it comes to airborne or aerosolization, you find that it can be in the air for longer and for a greater distance. And in the Lancet recently, there was a lovely editorial which you are referring to, which they stated 10 points arguing for it being airborne, the possibility of being airborne in addition to there being droplet transmission. So it's not one method only, it is a combination of methods. This is so important clinically because when it comes to should we wear masks indoors? I mean, the UK, in several other countries, the recommendation is still to wear masks indoors, in public transport, etc. In the US, what they say is if you're vaccinated, if you're completely vaccinated and received 2 doses, we have to remember they have got the best vaccines, the Pfizer and Moderna vaccine. They're completely vaccinated, then they don't need to wear a mask indoors. So it varies across the country. WHO has one criteria, but the general idea is to follow the safer process in the world. And in the UK, we go with wearing masks indoors as at the present moment. That might change in July, but at the present, mid-July, but at the present moment, it is wearing masks indoors.
Right. Now, this COVID-19 pandemic, since its beginning in November 2019, has seen various variants of concern. Initially, it was the Alpha variant from the UK, then there was the Beta from South Africa, then the Gamma from Brazil, and currently doing its rounds is the Delta variant, which has been ravaging India so far. And we know that this Delta variant is deemed to be 50% more transmissible and supposedly causes more severe disease in those who get it. So, what is your idea about this Delta variant and how does it compare to the other variants of concern which were there previously?
Yes, so Alpha variant, the UK, and then it spread around the world. Then the Beta and the Gamma came in, as you explained, and then the Delta variant took off from India. And now it has spread to more than 100 countries in the world. And the issue was it binds better to the receptor on the cells, it's more transmissible, so it spreads very much more rapidly. And the issue is the effects that we are concerned is what is the effect of the vaccines on the Delta variant, because that's what is important for us. And disease severity. There are 5 things that we are concerned when it comes to variant: the transmissibility, severity, affecting diagnosis, does it affect the treatment, and the vaccine responses. So the Delta variant at present, studies have found that 1 dose of the vaccine gives only about 30% protection, 35% protection. So you have to have 2 doses of either vaccines that were used in the study, that is the Pfizer vaccine or the AstraZeneca vaccine, to get better protection. We know that the Pfizer vaccine protection was far better than the AstraZeneca, but that is an important take-home message to remember, that 1 dose alone would not give that boost when it comes to the Delta. And that is why in the UK, there's a big rush to vaccinate as many people as possible in a short period of time, so that you get that complete vaccination or fully vaccinated status. And that is an important thing to remember. The US is doing the same thing, but we have to remember at the present time, the number of cases of Delta are increasing, even in Europe. In the UK, there are more cases of Delta, 160,000 till now. There are more cases of Delta in this week than the whole of Europe. So this virus is spreading around, and we have to take that into account. We have to remember about the Delta Plus variant, which has come in. You be possibly wanting to know some aspects about that too. And that again has to be kept. We have to keep an eye on that variant in addition to the Delta variant, which seems to be spreading around the world.
Right. Talking about the vaccine effectiveness and efficacy against this new Delta variant, we have seen that some of the deaths that occurred in India were of people who got both vaccines of the AstraZeneca. So, does that mean that the AstraZeneca vaccine has been deemed redundant against this new Delta variant?
No, it's not redundant, because the study that was done, we want to see the data properly, because there is a lot of, if there are 2 deaths, it's reported and then it can be blown out of proportion. We really want to see the complete data sets coming out. From the public health study, you found that 2 doses of the Pfizer vaccine 14 days after the second dose had a higher effectiveness compared to the AstraZeneca vaccine. And still the AstraZeneca vaccine was definitely effective against the Delta variant, especially preventing people getting to hospital, getting to ICU and dying. So there would be some patients, we have to remember, when we vaccinate across the board, there are some patients, that is the important aspect that is coming on, certain patients who may not make a good immune response, especially the immunocompromised patients, patients with cancer, etc., and patients with autoimmune disease who are getting steroids or immunosuppressive drug may not make an excellent response. And some of those deaths may be accounted from those other comorbidities, which have to be studied, and then specific routes have to be taken. If I give you an example, in Germany today, the guideline changed. Now, what would be happening in Germany from now on is people receiving the first dose of AstraZeneca vaccine would get a second dose of the Pfizer vaccine, because we know that the Pfizer vaccine, the AstraZeneca Pfizer vaccine boost, antibody boost at least, and T cell boost is very much higher than AstraZeneca. So from today, that guideline changed, and people would be receiving the Pfizer vaccine as a second dose. Even in the UK, people are looking at the vaccine booster that may come just before winter starts. And in the European countries, again, they're thinking about that. And it appears to be in the direction of giving an mRNA vaccine, that is the Pfizer or the Moderna vaccine, to produce that effect. So when it comes to the Delta, yes, there have been breakthrough infection. We have to get those sort of studies been looked at carefully to identify who are the people who are breaking through and getting these infections.
Now you mentioned about this Delta Plus variant, sir. We have seen other variants come and go, but we have not seen a sublineage being classified. Why have we gone on to classify a sublineage of the Delta variant as the Delta Plus? And what sort of impact does it have in our efforts to eradicate this pandemic? How does it compare to the original Delta variant itself?
So the Delta variant now was also referred to as a few weeks ago as the double mutant or double variant or double mutant, because it had two critical changes in the part of the virus, the part of the spike protein that binds to the receptor. Now that was why it was called double. It doesn't have only two mutations, but it had two critical mutations. And those critical mutations have been found previously in other variants found in other parts of the world. Now, while they were studying, they were collecting and sequencing or looking at the genetic structure of the virus, they found an additional change, the K417N, just for anyone who's interested. And that change has been found previously in the beta variant, the South African variant, and that was responsible for a reduction in vaccine responses. So that was why people set up and took interest in that, and it was classified in India as a variant of concern, because that means it has two critical mutations in the Delta variant, the original Delta variant. Then you have another mutation which has effects on vaccine responses coming into play, and that is called a Delta Plus variant. So that is why people are monitoring it. It is in less countries, say about 11 countries at the moment. The numbers are not increasing as rapidly as the Delta variant, but that has been observed very carefully across the world. And sequencing or looking at the viruses to see what proportion of the cases would be the Delta Plus variant.
Right. When we consider the previous variants of concern, Professor, we saw that the pediatric population was not so severely affected. But in the current context, we see that the children are getting more severe disease, specifically the multisystemic inflammatory syndrome in children. And also, we know that there is very minimal clinical trial data regarding the vaccination of children. In this backdrop, what is your opinion? Should we move forward with vaccination of the children, or should we wait for more clinical trial data to emerge?
So vaccination of children have started in Canada, in the US. Quite a number of children have been vaccinated, and in the UK, they are proposing to start it before the school term starts. We know that as the Pfizer vaccine, those over the age of 16, it was approved for those over the age of 60. So now, as the older population, because in the UK, they had a very, very clear pathway of vaccination, initially the older population, healthcare workers, etc. And then there was a reduction in the vaccine was given to those of a younger age. And now you can see that those over the age of 18 are being offered the vaccine. So if you look at it as a proportion, you would see that if you take people over the age of 50, a higher proportion of those in the UK would be vaccinated as opposed to the proportion of those between 18 and 25. So they are effectively, the younger population does not have immunity, and therefore there's a higher chance of them getting the infection, because the virus will try to get from person to person, where the next person is not immune to the virus. They'll be able to get a hold on that person. So the important thing at the present moment is to vaccinate, and that is what the UK is doing, vaccinate all adults over the age of, now it has come 16, over the age of 16 with one of the COVID vaccines. And the vaccines that they are using in the young person is the mRNA vaccines, that is the Pfizer vaccine and the Moderna vaccine. In the US and Canada, already those over the age of 12 are getting the vaccine, and this could be widespread, especially if you find these new variants taking off and spreading. Now, there is a flip side to this, because there are, as with the booster doses, we have to remember that you need more vaccines. Now, the issue is there are places in the world where healthcare workers have not received even one vaccine. And here we are trying to give people boosters. We're trying to vaccinate children who are generally at a lower risk. So we're trying to vaccinate to protect the adults. And there is a lot of discussion at the moment in the world. Is that equitable? Is that the way the world should go? Should they try to have a more suitable process going out across the world, rather than only one country considering and vaccinating specific, the whole population to the extreme?
Now, Sri Lanka is facing a logistical conundrum where the people who got the AstraZeneca as the first vaccine, they haven't yet got the second vaccine. And we saw that Oxford had released some clinical trial data where they say that lapse of 45 up to 45 weeks is acceptable. But in the current context, does this still hold true, or will this delay affect the levels of immunity in these people when they eventually do get the second vaccine?
We have to take into account the Public Health England data. One vaccine, AstraZeneca or Pfizer, was given only 35%, effective. So we cannot ignore that. And the important thing is that if you don't get a booster, and this is what the practice that is considered by a lot of immunology, you have to get a booster to get the levels to optimal levels with regards to both antibodies and T cells. So the important thing to remember is there is a shortage of vaccines around the world. This is a global phenomenon. And the interesting thing is that the vaccine mixers, the studies from the vaccine mixers have come out. And what it shows is that those receiving the first dose of AstraZeneca and then receiving the Pfizer vaccine as a second dose, the antibody responses and T cell responses, that's white cell responses, are much better than those receiving 2 doses of the AstraZeneca vaccine. Now, that increases the choices that are available to different people, and that is important. First, it was shown in the Spanish study, very recently in the Oxford study, where they found that the combination, that is why Germany, Sweden, France, etc., in the younger people, they were going with the first dose AstraZeneca and second dose with one of the mRNA vaccines. So the important process that is followed by many countries at the moment is vaccinate quickly. Don't look on and wait, because, as the Americans would say, it is vaccination together with social distancing that is important, but vaccination appears to be having a very, very cornerstone process that is vaccine immunity in getting this pandemic under control. And you can see across the world, places that are opening up are areas that have really vaccinated to a higher proportion than others. We have to remember the US has vaccinated close to 48%, two vaccines, while in the rest of the world, it's only about 11%. So the rest of the world is lagging behind. And that is why they're pushing forward and vaccinating soon. In the UK, when the Delta variant took off, they brought the interval from 12 weeks, 10 to 12 weeks to 8 weeks. And now people are being called at 8 weeks. So they are shortening it. And that is to get effective immunity to the people.
Right. And also Sri Lanka is currently looking at, like you mentioned, mixing of the two vaccines. We are looking at the Pfizer and the Moderna as the possible second dose for this AstraZeneca vaccine. We know that, as you mentioned earlier, the Pfizer and the Moderna employ the mRNA technology, whereas the AstraZeneca employs the viral vector technology. Moving forward, mixing these two types of vaccines which employ different types of mechanisms, is it safe for the people to mix these two vaccines, and how effective is it? As you mentioned, there had been recent clinical trial data which suggests that mixing of the AstraZeneca and the Pfizer, or AstraZeneca and the Moderna, seems to have given better results than getting two jabs of the AstraZeneca itself. So what are your thoughts on this, Professor, about the mixing of the vaccines?
Yes, Dilshan. I think studies have come out, and there are about 7 studies that have been published. Interim data, because more data will be coming out. And it appears to be going on the direction of the need for mixing, which the earlier studies, the interim studies, the preliminary studies are showing that AstraZeneca, the viral vector vaccine, with the mRNA vaccine, Pfizer and Moderna, is very similar, is producing better responses without any major adverse effects. There was a slight increase in adverse effects for one day, etc., but it was not of very high clinical significance. And at the moment, the immune response appears to be better when you combine the vaccines as a viral vector with which is the AstraZeneca, together with the Pfizer. Now, we have to remember that now everyone will be piling into the mRNA vaccines, and that has to be taken into account, because how are we going to get these vaccines? Because there is a finite number of vaccines. The supply side of the equation has to keep up with the demand side. So the mixing appears to be coming in. The preliminary studies show that, and we are waiting for other studies to come in. And then mixing would also potentially occur when the booster dose is given at a time that is determined by the different studies.
Right. And since we're running short on time on Healthline, as a closing statement, Professor, earlier you mentioned that certain countries are opening up. They are declaring mask-free zones where a significant percentage of the population have gotten the vaccine. And even as we watch the matches that are currently being held in the UK, we see that the spectators who come in are not wearing masks. So that might give a false sense of protection for the people in Sri Lanka. As a closing statement, please tell us and the people, how should we, especially in Sri Lanka, continue to protect ourselves as we continue rolling out the vaccines and moving forward? How should we continue to protect ourselves?
I would say vaccine rollout rapidly should go hand in hand with social distancing, together with hand washing, mask wearing, etc., because those processes will reduce the transmission to an extent till a sufficient amount of people get immune to the virus using vaccination. And we know that we have good vaccines at the moment. We may need to boost it to get better levels. But if we can, at least initially till we get good immunity, go with both vaccination and proper and sensible social distancing measures, that would help to reduce the overall sort of disease transmission and then disease burden, and that will prevent hospitals being overtaken and the deaths, ICU care, etc. occurring.
And there you have it. Even if you have gotten both doses of the vaccine, you still need to wear the mask and still need to practice the social distancing etiquette that we are used to. And that brings us to the end of the first program of Healthline right here on TV1. And until I catch you next week with your weekly dose of wellness, this is Dr. Dilshan Fernando signing off, wishing all of you Ayubowan.